So good morning and welcome to today's webinar. This webinar is brought to you by University of Illinois Extension and Rural Partners, which is the Illinois Rural Development Council. My name is Ann Silvis. I'm with University of Illinois Extension, and I also serve on the board of directors for Rural Partners. So today I'm wearing two hats. Before we get started with the content of this webinar, I want to share a few housekeeping details. First of all, I want to remind you all that today we have 2 hours for this call. So we have 1 hour for Laura to present, and then we've allocated another hour for questions and discussion if we need that. We might finish early, but if we don't, Laura is ready to go after that first hour, so no need to rush. Because we have so many people on the line, please mute your mic and stop your video. If you have questions or comments to make, even during the presentation, please use the chat space. I'll watch that chat space and make sure that Laura has a chance to answer all your questions before we finish up. If you have audio difficulty, post those questions in the chat space and we'll provide some technical assistance to get you back online. And finally, I want to remind you that the webinar is being recorded and it will be available later on our website. And when that's posted, you as a participant and registered participant will get an email saying that it's ready. Now, I'd like to introduce Laura Hepkessel, our presenter for today. Laura is the Director of Telehealth Services for Southern Illinois University School of Medicine. And this year, Laura is also serving as chair of the board of directors for Rural Partners. So thanks, Laura, for joining us.
Yes, thanks, Ann, and thanks to Extension for hosting the webinar and working with us on this series. So again, welcome. I wanted to talk to you all today about telehealth. I'm going to go through a presentation. As Ann said, we'll have time at the end for questions and conversation. I'm going to talk to you a little bit about what telehealth is. I think there's probably different people on the line know a little bit more than others, so I'm going to try to give you some of the basics and then go into how the SIU School of Medicine tackled, I'll say, the pandemic in the spring and how we continue to work through that. Telehealth exploded for everyone this past year. And so you'll get to see some of the numbers associated with that for our organization and what the future holds. So we'll get started. All right, a little bit about SIU School of Medicine. So SIU School of Medicine was established in 1970 as a community medical school. We celebrated 50 years last year, and most of our celebrations were canceled due to the pandemic, but nonetheless, 50 years. If you don't know what a community medical school is, essentially we are based in the community and we have relationships with our partner hospitals. We do not own our own hospital. So community medical schools are, there are a lot fewer community medical schools versus medical schools that own their own hospitals. We do have a defined service region of Central and Southern Illinois. The number fluctuates a bit, but 66 counties or so is the kind of the service region that we see is our what we are responsible for serving. Our 4 areas of excellence within the school, we focus on medical education, patient care, research, and community service. So our faculty members spend part of their time in the clinic and part of their time helping, teach and work with our students. Our first year students usually spend that first year in Carbondale, and then years 2 through 4 are in Springfield. Although that's recently changed, and we have a small cohort that's going to spend all 4 years in Carbondale and have even more of a rural focus than what we already are offering our students. So we also, SIU Medicine is sort of the broader term that encompasses our multidisciplinary clinics, with patient-centered focus. We have clinics in Springfield is where our main campus is located, but we have clinics in Quincy, Decatur, Taylorville, Lincoln, Carbondale, starting residency program in Alton. So we have a kind of a broad footprint across Central and Southern Illinois. We have world-renowned research, including in cancer, Alzheimer's, and audiology. If our dean was here, he would talk about the triple aim +1. You want healthcare that is healthcare and education that's more effective, efficient, equitable, and enjoyable. So we're always trying to strive for that. Okay, so what is telehealth? I borrowed this definition from healthit.gov just to better explain. I tend to use telehealth and telemedicine interchangeably, but I wanted you to know there is a difference. It just may not be clear in what I'm saying today. We call most things telehealth, but telemedicine is more the clinical focus. So HRSA will define telehealth as the use of electronic information and telecommunications technologies to support long-distance clinical healthcare, patient and professional health-related education, public health, and health administration. Technologies include video conferencing, the internet, store and forward imaging, streaming media, and terrestrial and wireless communications. Telehealth is different from telemedicine because it refers to the broader scope of remote healthcare services than just telemedicine. While telemedicine refers specifically to remote clinical services, telehealth can refer to remote non-clinical services, such as a provider training, administrative meetings, and continuing medical education in addition to the clinical services. So there's another definition that says telemedicine refers specifically to interactive health communications with clinicians on both ends of the exchange. So if you have a clinician on both ends, it's going to be more telemedicine. Otherwise, the broader umbrella would be telehealth. Okay, so pre-pandemic, what telehealth looked like here at SIU School of Medicine, but also at a lot of other places. So before COVID hit and some of the restrictions were loosened a bit, we used terms like originating site, which is a Medicare term, and that's a location where a patient would go to a qualified facility to receive telehealth services from a provider who's located at a distant location. So an example, we would have a SIU provider. A lot of times it's a specialty provider of some sort, dermatology, pulmonology, endocrinology, rheumatology, that would be located in Springfield, for example. And we might have an agreement with a hospital in Sparta or in Jacksonville or in Lincoln, and they would have a telehealth cart there, which I can talk a little bit more about. And so the patient would go to that local healthcare facility. So it might be 20-minute drive for them versus an hour and 20 minutes to get here. And so they would go there. There's usually a telepresenter, or which is normally a nurse, sometimes a medical assistant, that would be located in the room with the patient while they're seeing our provider on the other end. So there's a picture of a cart later, but as some of you might have heard us discussing before we got started, the cart behind me is one of the carts that we build in-house, and that would be potentially located at one of our partner healthcare facilities. So there's a list of originating sites. So it's going to be a healthcare facility of some sort, rural health clinic, physician practitioner office, hospital, FQHC, et cetera. So that would be likely where the patient would go. And I should have said the originating site, there are a lot of rules, pre-pandemic rules about health professional shortage areas, and it has to be in a rural area, and there's different criteria to meet that to be that originating site, especially for Medicare. All right, so distant site practitioners, again, a Medicare term, can provide reimbursable covered telehealth services from a distant location to a patient at an originating site. So it goes back to, we might have a physician, nurse practitioner, midwife, certified registered nurse anesthetist, registered dietitian, whoever might be on our end seeing the patient on the other end. And the way that's usually handled is from a billing perspective is that we would bill, as the provider would bill, the professional fee, and then the location where the patient is with the telepresenter, they bill what's called a site fee, originating site fee or facility fee. So they get a small, I don't want to tell you the number. I think it's like $25 to $30, somewhere in that range, that they would get for hosting the patient there. And then, of course, we would bill for the actual professional fee for the physician services. The benefit of that setup, of course, is that you keep the patient in their home community. They keep their prescriptions locally. They keep their lab work, x-rays, blood work, whatever they might need. Then we would issue whatever's, orders, whatever's needed, and they could get that done at their local hospital. So it's keeping more of those dollars in their local community, as well as not requiring them to have, childcare, transportation, all of those things that they would need to get to their appointment if it was further away. And my pictures aren't showing up, so that's not good. wonder what happened to them. So if this was, if this looked, can you see the pictures, Anne? No, okay. I apologize. There were some nice pictures here to show you what our cart looked like, but you can see the cart behind me. And so on the cart, which would be at the originating site where the patient is, we have a stethoscope, otoscope, a handheld camera that can really zoom in and see, if somebody has a rash or a wound that the doctor really needs to see. And then the camera on top, most of the time it's just used as a regular camera. But for instance, our neonatologist, sometimes if there's a baby at another facility, they're trying to work, the neonatologist can control that camera from afar to zoom in and see what they need to see while the practitioners on the other end are actually trying to work on the patient. And there was also a map on here that you can't see, but it kind of shows where we have telehealth carts in Central and Southern Illinois. We've been going back and forth with this number. We probably have about 25 or 30 carts total, but some of them are used more for internal purposes and others are with external healthcare partners. So we've got a number of sites in Central and Southern Illinois. In addition to what the norm, if you will, what I had just described at other healthcare facilities, we also have agreements, especially for psychiatry, with correctional facilities, for the state Department of Corrections, as well as sheriff's offices, where we provide hourly psychiatry services to folks that are incarcerated in those locations. So telehealth to the home, or it might be referred to as direct to consumer. This was the expansion that happened due to COVID. So COVID, hit Illinois, we'll say, and we were told, I think on a Monday, that we needed to set up some sort of telehealth to the home structure that we were not doing before. So within 3 days, we onboarded our Department of Psychiatry to start doing that using WebEx, which most of you probably know is a video conferencing system that works really well for video conferencing, but it is not built specifically for telehealth. So there were some issues that we needed to work around, but we already had a business associate agreement in place with WebEx. It was safe and secure. It was our best chance of getting something up and running quickly instead of trying to go through a contract process with a different vendor at the beginning of the pandemic. So within 3 days, we onboarded psychiatry, and we continued onboarding additional divisions and clinics over the next few weeks, probably actually the next few months, but we continued to go back and work with more providers as time went on. And daily we were tweaking and trying to improve the process, run into something we hadn't thought about because there wasn't time, or just something that we weren't expecting, or we ran into a new issue. We joked about we were trying to build the plane as we were flying it and it was on fire, something along those lines. So it was just a constant trying to tweak and improve and make things work. So along with that was a lot of patient, provider, and staff education. So no one had used WebEx for telehealth before. And we had some providers that had been doing telehealth before, but it was a very small group at the school here that were doing telehealth. So a lot of education, both verbally in person, as well as creating documents, trying to explain things. And we also thought it was important for us to survey both patients and providers as we went along through the process. We wanted to get feedback. We wanted to continue to improve the process. We went ahead and surveyed patients right away. And there's a little bit more information about those surveys later, but I think we surveyed just under 2,300 telehealth patients in the first couple of months after the pandemic started, with a phone call after their appointment. And then providers, we waited until summer and then surveyed them to see who was interested in doing telehealth long-term. Feedback, again, gave us information to focus on improvements in the future.
Laura, this is Anne.
Yeah.
Nancy, I just wanted to say that Nancy put that image in the chat if anybody wants to look at the map. Or I could also briefly share my screen if you wanted to go back to that map and show it. So you let me know if you want me to do that.
If you want to share your screen, that's great, Anne. I should have checked, but I don't know why that didn't show up on my side.
I guess if I do that, then you won't be sharing your screen anymore.
Okay.
So
maybe at the end we can come back and show would that work?
Yes.
Okay. So I think the most important part of this is that it takes a village or an army, depending on how you're looking at it. We could not have expanded telehealth at the beginning of the pandemic like we did if it wasn't for the telehealth office, which there's only 2 of us, information technology, and my colleague Ben Kirchhoff is on the online as well, and he'll be around if we have questions for him later. He can contribute. I talk to information technology daily, multiple times a day, different people trying to get things set up. Definitely couldn't do any of what we do without them on a regular basis, but especially at the beginning of the pandemic. Our compliance office, administration, clinical informatics, they have nurses that are located in each department. So once we realized that, we started having them come along with us when we were onboarding so that they could kind of backfill once we were gone and moved on to the next clinic. They could help continue that education. Our healthcare core, which is the chief operating officer in that group, clinical staff and providers, of course, marketing, communications, research, helped us with the surveys, and a reassigned team was created just to handle scheduling. Scheduling was in itself was a huge undertaking. Right. So continue to talk about that expansion. So our growth started in March and April because of the pandemic, obviously. We expanded our telehealth appointments. Instead of just offering that traditional, which is where the cart's at another location, we expanded that to the telehealth to the home and direct to consumer. In the year 2019, we had approximately 2,000 telehealth visits. In the year 2020, we had over 63,000 telehealth visits. So that shows you how much we grew just in a year. May, when there was a stay-at-home order in place, we peaked at over 12,000 telehealth visits in May. And then we, March and April, where we're kind of building up, peaked in May, and then it started dropping a little bit the rest of the second half of the year. But we averaged about 6,300 visits per month from March to December. And I think we were about 6,000 visits a month for the last quarter of last year. So it'll be interesting to see how that, what those numbers look like in this coming year. But it was very interesting. The one thing that I mentioned earlier about especially our Department of Psychiatry, who has individual contracts to provide hourly services, psychiatry services to patients at correctional facilities or even some hospitals. Those telehealth numbers are not included in the numbers I'm giving you. These are going to be more of our outpatient telehealth, but that's also another part of the telehealth work that we're doing. And let's see, I mentioned in January and February, we had less than 200 telehealth visits a month, which was less than 1% of all visits at the school. By May, when we were up over 12,000, that ended up being 46% of all our visits in May. So it was very interesting to see that number increase. Other parts of the expansion are no-show rates in the last quarter of 2020 for in-person visits where we have patients coming into the clinic. The no-show rate was approximately 16,000. Sorry, not 16,000, 16%. For telehealth appointments in the last quarter of 2020, it was only 7%. So that's a huge number. What we're seeing is once folks got used to using the telehealth platform and were more familiar with it and used to it, we were not having near as many cancellations or no-shows. So our primary care services saw a jump in telehealth visits. So 54% of family medicine visits and 81% of general internal medicine visits during the month of May were telehealth visits versus in person. Over 95% of our psychiatry visits, 53% of pediatric specialties, and 54% of internal medicine specialty visits were telehealth during the month of May. And our Department of Psychiatry was able to maintain 96% of their normal volumes through telepsych services with patient satisfaction scores at or better than pre-COVID-19 visits. So that's important that patients enjoyed it. They weren't just forced to do it, but it was better for them. They didn't have to take off a half a day to come in for a 40-minute appointment. They could just be available for the 40 minutes when they had the appointment and go on with their day. And as the pandemic has continued, psychiatry is still offering about 50% of their mental health outpatient services via telehealth. So I think as long as reimbursement changes are made permanently, I think psychiatry will continue to offer at least half of their services via telehealth in the future. So telehealth to the home, again, we're continuing with patient satisfaction from that perspective. From mid-March to late May, I mentioned those phone interviews with almost 2,300 patients. Over 70% of the telehealth patients that we surveyed said they would like to continue to see their provider via telehealth after the pandemic. So that was huge. It let us know that we needed to figure something out for the future. On a scale of 1 to 5, 83% of our telehealth patients surveyed indicated that the highest ranking, which was 5, they would recommend SIU School of Medicine to others. So we use that question as one that was used on our other surveys we were doing with in-person appointments, so we can have a comparison to see what telehealth numbers look like compared to the inpatient numbers. Okay. As far as provider satisfaction, that survey that we sent to providers in summer of last year, we had 139 respondents, which isn't a huge number. That's probably a third or fourth maybe of our providers. So 2/3 of those who responded would be interested in seeing patients in the future via telehealth, and 2/3 were comfortable with residents seeing patients via telehealth. So obviously we're academic institutions, so residents are a big part of our clinic setting. So that was something we wanted to ask. 92% of our providers believe they feel present during telehealth appointments. 68% of respondents were highly satisfied with providing telehealth services and ranked their experience at an 8 out of 10 or greater. And a third of our providers thought that they could see 76 to 100% of the care given via telehealth in the future. And 80% thought it was an efficient way to provide quality care. So we thought those numbers were important as we planned for the future to know where our providers were and what they were thinking. Okay, so some challenges. I mentioned WebEx. It's a wonderful administrative video conferencing tool, not ideal for telehealth. They have made some improvements since the beginning of the pandemic that makes it a better option, but in the beginning it was, we had a little bit of difficulty trying to figure out what that looked like. So it's not as user-friendly if you're not in an office setting and working, doing video conferencing a lot. That it was just a little bit more difficult for people to get used to. And early on, you had to download their software in order to use it. I think that's changed since then, but that made it difficult too, because folks couldn't just jump onto a call. They had to actually download the software in advance, or the program. And we had people calling patients trying to walk them through that days in advance of their appointment to try to set them up to have a more successful appointment. As I mentioned, scheduling. So scheduling before would be putting the information into our scheduling system, and that still had to happen. But beyond that, then we had to schedule the WebEx visit as well and make sure that information got to both the provider and the patient. We were trying to figure out how to mask the email addresses of our providers. We didn't want patients to start emailing providers. That's not something that normally happens. That would happen through our patient portal, not through a regular email system. There were just a lot of scheduling issues to try to work through, and they continue tweaking those. We also, had to think about whether you put the patient's name in the subject line or not. Whether we might put psychiatry appointment, but if someone has a shared email address with someone else in their house, they may not want the other person in their house to know they were seeing a psychiatrist. So we had to work through a lot of those issues to try to make sure that we were doing something that worked for everyone, and it was also keeping our patients safe and worrying about their privacy. Some of the barriers for patients, digital literacy. As I said, some of them had never used a video conferencing system before. One thing, if you work in a professional setting, you might get a calendar invite for a meeting. And when you accept that calendar invite in your email, it goes on your calendar, but then it disappears from your email. That's what was happening with patients. But if they didn't work in a professional setting where they were used to that, they would go back the day of their appointment and couldn't find the information in their email because it moved to their calendar. So we had to figure out a way to send them that information separate in an email so that they could click on it and wouldn't just accept it and it disappeared. Of course, reliable internet connections are necessary. Some folks might have internet, but they live out in the country and it's not reliable. It wasn't enough to have the video portion, or they may not have the access to technology that they needed. They may not have a smartphone, or I was in a clinic one day and the person didn't have storage left on their phone for them to download the app and things like that. So there's all kinds of issues around technology and with the patients that we tried to work through. As far as providers at the beginning of the pandemic, access to equipment. So again, most of our providers were not doing telehealth prior to the pandemic. So most of them had an office computer, but it likely didn't have a camera, maybe didn't have a good speaker. We were constantly trying to order webcams, speakers, headsets, docking stations. Some people, we had providers that were in quarantine at home, but still wanted to see patients, and they could do that via telehealth the way the rules were loosened. So, but we had to get them set up at home to be able to do that. So in the beginning, it was just a real scramble trying to get our hands on additional equipment because everyone was trying to do the same thing we were. We did figure this out, but it took a while to try to figure out how to integrate our interpreters, including American Sign Language, into the telehealth process. So the way it works in the clinic, we have a iPad, I think, in the clinic spaces, and you would call the vendor that we use for the interpreters, but we couldn't, we can't get them to call us. So we had to figure out how to make that work with the video conferencing system and how to schedule. We had to figure out how to schedule the ASL interpreters as well to be part of the appointment. So it was, that was something that we had to figure out once we ran into that issue. We had to develop new forms, patient provider instructions. We're constantly editing and changing those as we figured out a better way to do those. And then of course, patient marketing. So a lot of patients didn't know what telehealth was and didn't understand how they would need it. So we had scripts to call patients and say, we want to switch to telehealth. We need to know what access you have to technology, internet, et cetera, how comfortable you're doing this so we can know if we can switch you. Of course, some patients prefer to come in person, and but during the beginning of the pandemic, when things were really unknown, we didn't want people in the clinic if they didn't have to be there. So if it was just going over medication management, reviewing test results, things like that, we really wanted the patients to stay home so that they didn't get exposed to us or other patients, and we didn't get exposed to them. So we really had to work on those marketing tools to make sure that they understood what telehealth was and how to utilize it and why it was important. All right, so when you think about the expansion, I mentioned some of the barriers already, but for providers, it was our lack of cost and access to high quality web cameras and speakers and laptops so that they can conduct those telehealth visits in the office, in the clinic, or at home. And we did have some providers that were just uneasy using that technology to see patients. They just hadn't done it before. For our patients, again, lack of cost and access to computers or smartphones with cameras and speakers, as well as consistent, reliable internet service and the technology literacy that I mentioned. But the benefits, beyond those barriers, the benefits that we saw for providers, it was the flexibility to see patients from outside the clinic. They could be out of town, in quarantine at home, et cetera. And then also the need for an actual telehealth platform versus using a video conferencing software to provide telehealth. So it's a better experience for both providers and patients if you're using an actual telehealth platform. For patients, economic reasons, as I mentioned, they miss less work, childcare, transportation, just save time in general, convenience, and less exposure to others in clinic spaces and waiting rooms. So these are all reasons we feel like we need to look at expansion. There's barriers to overcome, but there's also a lot of benefits that go along with it. And when you think about the improvement in care quality, some people think that telehealth doesn't offer as good a care. I think that there are some appointments you really need to have in person, and that's between you and your provider. But for some of our providers, I heard them say, the patient would try to describe to me their home setting, and it was hard to understand until they were actually on the video with me and I could see who was in the house with them and what kind of environment they were in, or they would forget what kind of medications they were taking. So I would just say, take your phone in and show me the medicine cabinet and we can look at it. So there were also a lot of improvements in care quality because providers were able to see a part of a patient's life that they don't see when they come into the clinic. So the biggest barrier, though, to telemedicine is the reimbursement rules pre-pandemic. So Medicare limits where the patient can be located. Again, it's based on health profession shortage areas. You know, for Medicare, Decatur is considered urban. So we might have patients that live an hour on the other side of Decatur, but if we can't offer them telehealth services at one of our clinics in Decatur, for instance, and they got to drive another 45 minutes to get to Springfield. And as well as the physical location of where someone's located. So it also requires both video and audio connection. And another example would be for telepsychiatry. So if our psychiatrists are providing inpatient coverage or ED coverage for a hospital, and they need to see a patient daily because of whatever psychiatry issues they're having, we only get the provider would only get reimbursed for seeing them every third day. So even if they see them days 1, 2, and 3, they're only going to get reimbursed for day 1, and they don't get it reimbursed again until day 4. So that makes it difficult. You know, there's a lack of psychiatrists across the entire state when we can provide that service, but we can't get paid for it for hospitals that really need it. So although at the state level, we can't control Medicare, obviously that's a federal issue. What's important to understand is that Medicare rules are often the default when the state doesn't have specific telehealth laws enacted. So we really need to focus on expansion at the state level for both Medicaid and other payers. And the good news is that CMS just released at the federal level, I think at the end of last year, beginning of this year, where they have made some permanent expansion of telehealth. So we're headed in the right direction at the federal level, but we've got to make some more progress at the state level to make sure that we can continue offering these services that are needed and providing more access. I'll tell you a quick story along these lines. When you think about, you know, a patient might save 20 minutes or an hour or something to get to the appointment if they're doing it via telehealth. I received a call from a mother a few months ago, and she was Chicago based and had a child. I don't remember if it was a son or daughter, but that she said that she hadn't been able to get in to see a child psychiatrist since the pandemic started. And luckily, we're able to see those patients right now via telehealth, and we have a child psychiatrist, and we accepted their insurance and we were able to get her in, and she was so happy that we were able to get her in. So we're seeing patients from outside of our what you would consider our normal service region because they don't have access where they're at, and we can provide that access via telehealth. So it's just great to be able to link those people that need those services with the resources that we have already. So as far as the future of telehealth at SIU School of Medicine, we are currently in the process of securing a telehealth specific platform for future use and for telehealth to the home and direct to consumer. And we think it will also work in replacing the software that we use on our traditional telehealth carts as well. It'll be more user friendly for patients, providers, and staff. Device agnostic, it's web-based, they won't have to download software. It prompts the patient to test their technology in advance of the appointment. It gives us the ability to have patients to complete forms online before the appointment instead of us having to mail them. Patient tech support is provided. That's something that was a real issue over the last 10 or 11 months. So this platform will have tech support. The patients can call if they're having trouble with getting into their appointment. The platform will send reminder texts and emails to patients, and it allows for resident supervision, which again is a big part of what we do because we're an academic institution. It has a patient satisfaction survey built in, which, as I mentioned, that's important to us. We want to continue to hear from our patients and make sure that we are improving things as we go along. And after a software upgrade later this year, we'll also have the ability, if we choose to use it, that patients can self-schedule through the system as well. So we're excited about that. Makes things more convenient for the patients. So, and as I said, we're hoping that this will be able to replace the software we're using in our traditional telehealth program on the carts. And then our providers and staff will have fewer passwords to remember and logins and different, they won't have as many different types of software they need to get used to using. Hopefully we can just use one. Again, this is a map you can't see, but we will pull it up here in a minute. We'll show you the home counties of patients that have been served by SIU School of Medicine during the months from March to August 2020. And I believe this is going to show 88 counties. And what I will say that as of our latest patient numbers from the end of December, we've actually served patients in 95 of the 102 counties in Illinois from March to December of last year. So that's really exciting. And when we think about the patients, for instance, in Cook and the Collar counties that aren't necessarily in our service region, but obviously aren't always able to access the services they need where they live. From April to July, the beginning of the pandemic last year, for patients with home addresses in Cook and the Collar counties, they were able to access telehealth services from SIU for primary care, psychiatry, plastic surgery, pediatric genetics, neurology, and infectious diseases. So we're just glad that we can provide that care to folks that need it. And so that's the SIU story I was wanting to tell, kind of where we were, pandemic, and where we hope to be in the future. I also just wanted to provide some resources to you, telehealth resources. So if you have an interest in telehealth, you're welcome to reach out to me. And if I don't have an answer, I'll try to find someone who does. But also there's some great organizations in the state and nationally that are doing some really good work around telehealth. So the Illinois Telehealth Initiative is part of the Partnership for Connected Illinois. They provide online telehealth forums. They have a telehealth awards and recognition ceremony every year. So they do some really great work. Nancy Kazak directs those efforts, and I serve on that board. The Illinois Telehealth Network is a program or project out of the HSHS system, which St. John's Hospital in Springfield is part of. And they promote telehealth capacity for their members, and they assist with grant writing to get telehealth equipment. The Illinois Health and Hospital Association, or IHA, they have a telehealth coalition, and they're really focused on advocacy at the state level and federal level, actually. The Upper Midwest Telehealth Resource Center is located in Indiana, but covers Illinois. And they provide virtual office hours, stakeholder calls, conferences to offer assistance for telehealth, and they're federally funded. The Governor's Rural Affairs Council, the GRAC, which is chaired by the Lieutenant Governor, has a health and healthcare committee. I chair that committee, and we have a telehealth focus, and we're exploring some demonstration projects that we would like to do in the state in the future. And then the Center for Connected Health Policy is a national organization that really focuses on policy efforts across the country. So you can go to their website and learn about different policies regarding telehealth in different states. This was the first in a series of webinars about telehealth that's happening between Extension and Rural Partners. On Friday, February 12th at noon, there'll be a second telehealth webinar that you all are invited to attend, and I would encourage you to consider that if you have an interest in telehealth. Nancy Kazak from the Partnership for Connected Illinois and Matt Schmidt from DCEO's broadband office are going to provide information at that webinar. And then on Wednesday, February 17th at noon, Chris Merritt and one of his faculty members from the Institute for Rural Affairs at Western Illinois University are going to provide a telehealth presentation with a lot of good data and the value of telehealth to rural economies. So that's another great one to sign up for. So I want to just make sure that you're aware of Rural Partners. As Ann said, we're the state's Rural Development Council. We're a member-driven forum, the volunteer board. We try to link individuals, businesses, organizations, and communities with public and private resources to maximize the potential of rural Illinois. So we're always looking for new members to get involved. We are offering this webinar series this year since we couldn't meet in person as much because of COVID. Hopefully later in the year we'll be able to, but for now we're trying to offer a webinar series with a different kind of overarching goal or topic each month. So I would just encourage you, if you're interested, reach out. We can provide information. You can go to our website, which is ruralpartners.org, and learn more. It's a great organization to be a part of with a lot of great resources and people involved. So just encourage you to consider that. And then Western Illinois University has their Illinois Institute for Rural Affairs has an annual Rural Community Economic Development Conference. It's virtual this year. It'll be held February 24th and 25th online. And there's a lot of great information shared at that conference, including there's a couple of sessions focused on rural health and one specifically on telehealth that's going to be provided by one of our docs here at the School of Medicine. So again, if you have an interest in telehealth, another way to learn. And the conference is being offered at, I think, only $25 because they're able to do it virtually and receive some sponsorship support. So it's a really great opportunity for you to learn from different folks. All right. So
Laura, Laura, this is Ann. I'm wondering if you wanted me to share my screen for a minute so that you could
Sure.
go back to those maps.
Yep. Let me stop sharing.
Okay, so let me see. I think that this, can you see that? So this was the first one where you talked about a map that didn't show up.
Yep. So those are most of our external partners where we have telehealth carts located mostly at hospitals for all of those places. We do have carts at other locations that are more internal, but those are most of our external facing ones with some others in the works.
And then the second one that didn't show up was the REACH in Illinois, and you wanted to share the map about that
Sure.
too.
So I think this shows 88 counties that we had served as of the end of August. And as I mentioned, as of the end of December, we've actually served 95 of 102 counties. So each month we keep filling in a county or two. So I can't wait till that map is all purple.
Okay, I'm going to stop sharing and we can go back. And now there's one question that appeared in the chat that I wondered if you could address. Susan, my colleague Susan Odom asked, for some companies, insurance companies, for example, a dedicated internet connection that doesn't allow for Wi-Fi access is required for their remote workers. So did this issue come up for you with people working from remotely?
Just for people working remotely, I think we did have, Ben, you might be able to answer this better than I can, so please feel free to jump in. We did have issues with people having internet service at home, having technology at home, lots of things. So some people did come into the office even though they could work from home because they just didn't have the access at home. And other people, I think, decided it was worth it if they didn't have to travel to work and things like that and stay safe, that some people did go ahead and get that service. But I don't think that the school itself actually offered or covered that internet service at home if they didn't have it.
Okay. And did you restrict the ability of people or those sites that provided access to only like a line connection and no Wi-Fi access?
As far as our people working from home, or are we talking about telehealth? Sorry.
I'm talking about telehealth, I think.
Telehealth. So no, for people that were at home for telehealth to the home, they could do any Wi-Fi, home, anything. When we talk about our telehealth carts that are actually located at our partner sites, we require those to be actually plugged in. It's a stronger connection and better quality. But for folks at home, whatever they can get to work, we made it work.
There's another question that came in from Diane. She said, how is the northwest corner of the state going to be served? So
technically that's not in our service region. So that's not an area we probably focus a lot of attention and marketing in. It's definitely, I'm not saying they shouldn't get served, but I would guess that there might be some healthcare facilities closer to that area that can better serve them. But if they needed something, they can always reach out depending on what they need to be seen for. They might be able to be seen via telehealth, or they might be asked to come in and then they could make the decision whether that was a good fit for them. But hopefully there's some places in the northern part of the state that are also offering telehealth. I just can't tell you who they are right now.
And so is there are you aware of kind of a statewide network of healthcare providers that are thinking about how to make sure everybody's got coverage, or is that just covered because it's all remote?
So I would say that they're probably, just from a healthcare perspective, that there is probably statewide coverage for the most part, but as far as who's offering telehealth or not, I can't tell you exactly who's doing that. Other than I think that if we can get these reimbursement changes made, it's going to encourage more healthcare organizations to go down this path if they haven't already, because they're going to see that they can serve more patients and have a broader reach than they would have otherwise. So the Illinois Telehealth Network might be a good place to look. They might have their members listed on their website. I'm not sure. But again, that's Illinois Telehealth Network, and it's an HSHS St. John Hospital project. And then the Partnership for Connected Illinois might have some information on their website about different maybe examples or case studies of maybe what's happening.
Okay. And then Diane asked a more technical question, and when we're finished, you should look at that question in the chat, Laura.
Okay.
So then Margarita asked, how is this working with translation? What languages are the most requested?
Ben, do you have an answer for that? You want me to take a stab at it? Can you remember?
What languages are most requested?
Mm-hmm.
I mean, anecdotally, I would just say Spanish and American Sign Language.
Mm.
I'm sure we have that data somewhere, but I haven't actually.
Yeah. I think that whenever we tried to, again, we created patient instructions just for this pandemic telehealth. And honestly, they were 8 pages long, which I'm sure gave patients a headache, but we tried to do screenshots of every single thing they would see as they went through the process to lay everything out for them. And I will say that when we paid to have those translated into other languages, I think there were 3 or 4 top languages we had those translated into. Spanish, I know, was one of them, as Ben said, and I think there were 2 more, and I don't know off the top of my head what they were. I apologize. But I'd say there's 3 or 4 that probably definitely were serving more than the others, or else we would have focused on more than that.
Yeah. Matt Johnson is asking, given a large influx of new telehealth patients in 2020, what percentage do you believe may not have otherwise been able to make it to their appointment or never use the technology? So do you think the telehealth usage trends in 2020 will continue in 2021?
Yeah, I do think that telehealth will continue, especially as because we're still in a public health emergency. The loosened restrictions for the reimbursement, we're getting paid at the same rate we would right now if the patient was in the office. And even for, I believe it's Medicaid, you can even just get paid with a phone call. You don't even have to have the video connection if you can't make it happen. So again, the video adds something, and sometimes you need that video, but not always. Sometimes, again, if you're just talking, if psychiatry visit's a good one, or if you're just talking about medication management, you don't always have to have that video if it's not available. So phone calls are fine as well. But I think that, as I said, we went from 200 visits the first couple months to 12,000 in May, when really they were keeping people at home, and there were a lot of unknowns about the virus. And then as things kind of went throughout the year, we've averaged about 6,000 a month the last quarter of last year. So we kind of see that if reimbursement continues to be what it is now, or hopefully expands, maybe not to the extent, but close, we expect that we'll continue. I don't know if 6,000 is the magic number for us, but that's kind of where we're at now. So I do think that as long as reimbursement expands, we'll continue to see a lot of telehealth happening, and probably continue to look at what we're doing and what can be, there's some people I think that probably thought they could never offer any of their patients telehealth, but once they were kind of forced to do it, at least look into it because of the virus, I think there were some physicians that were surprised by what they could offer.
Laura, while we're talking about some of these questions, we're going to post a poll that people can respond to that just lets us know how much you learned, and we keep records on that so that we know it was a worthwhile endeavor. So you can mark that poll, and we can do this while we're still talking.
One thing I didn't even get into, because it wasn't something that fell within my within our office, but it happened at the school. We also received some funding from the state at the beginning of the pandemic, and we offered what you might consider remote patient monitoring. So for folks who have COVID, we were taking, I think, wellness kits to their homes so that they could, I don't know what all was included, but things to keep them busy, things to keep them safe and healthy. So there were some other things that were within the telehealth review, but they didn't fall under my responsibility, so I can't speak to all the details. But there's just a lot of good things, I think. I don't want to say good things that came from the pandemic, but there were some silver linings of things that maybe hadn't been considered before or hadn't been tried.
Do you have any word on future patient site locations? You mentioned briefly kind of the payment restrictions and how that influences site locations. Can you talk a little bit more about that?
Yeah, I think if telehealth to the home is paid for in the future, people can just be at home or at their office or at their neighbors or whatever. I think that will be the patient site location if it's offered. Now, there probably, or I'm sure there are still going to be some patients that are going to be better served by going to a local healthcare facility and having a nurse or someone in the room with them that can use the stethoscope or the otoscope or something on them and the doctor can see on the other end. So for us, we're willing to work with anybody. But of course, those carts cost quite a bit of money for us to build. And then you have to keep up with the software, annual licenses and software, and Ben and the rest of the IT team have to, troubleshoot when there's an issue and things like that. So I think that if there are locations that are interested in working with us on telehealth, we're always open to that conversation. But again, it'll just be interesting to see what's needed and what people think will be needed for the traditional setup where they have access to the peripherals and what can just be done with patients at home. So I don't know that I really answered that for Nancy, but I think depending on payment expansion, it'll continue to change over the next 6 months or something.
Well, Diane asked a question that I think is related. I know that she's involved at the county level as an elected official, and she says this has really been helpful to be aware of what when we begin comprehensive planning in the county. And I'm thinking back to both the state's interest in expanding broadband and local efforts to make their communities, counties more attractive to people moving in or businesses locating there. And healthcare, access to healthcare is always one of those, features that you want to be able to say, people can benefit from in your community. So this might be something that other groups might say, well, if we could provide a site or if we can, provide a site with good internet access, would that be a step toward having more access to healthcare locally?
Absolutely. That's one of the demonstration projects that we're considering as part of our work with the Governor's Rural Affairs Council and Lieutenant Governor's Office. No decisions have been made, so I don't want to make any promises, but we're looking at the possibility of some pilots or demonstration projects that will identify a couple locations, maybe in a very underserved area. It might be a library, it might be a Farm Bureau office, something like that. Where we would make sure there's a dedicated space that was private so no one could hear, there was technology there. Hopefully the staff would be trained a little bit on how to help the patient, and the patient, let's say they lived out in the country and didn't have reliable internet connection or didn't have internet at all, they could maybe just drive into town to their local library, or they may just live down the road and just don't have that connection. And there would be a safe private place where they could have reliable connection for their telehealth visit. So we're looking at options like that. And I definitely think I'm on the county board. I don't know that we talk a lot about telehealth at the county board level right now, but that's definitely something that needs to be considered. I think a lot of counties, it depends on where you're located. Some counties have, Springfield, Jacksonville, Decatur, all within 30 minutes or whatever the case may be, and they don't see it as much of a need. But again, just keeping patients out of the clinic space is going to keep them safer. They're not exposed to the other germs that are in the space. So I think it's important for everybody to consider. And I think more people are considering it now.
So okay. I'm saying that we had room for some more questions, and I wanted to remind people that Laura has her technical expert on the line as well. So if you're hesitant to ask some really technical questions, don't be hesitant, because I think Brian could address those. So Margarita asked, some insurance does not cover RDs or nutrition specialists. How is that working? And do you see demand for that?
So we do have RDs, I'm assuming registered dietitians. We do have some of our registered dietitians and nutrition specialists in our, I think, Department of Internal Medicine and Family and Community Medicine are seeing patients via telehealth. I worked with them to onboard them. And I think they're even thinking about or already offering some group classes on, maybe cooking class or nutrition class. So I think there is a demand. But again, it goes back to, you got to make sure you have the right software and platform, especially for those one-on-one appointments are different, but if you're going to have a group class, you got to make sure you've got the right platform that you can have 10 or 12 people or however many you have in that class, and everyone has an opportunity to engage if you want it to be more like a group. I'm a social worker by trade, so I'm thinking more of like group therapy, but if you want everyone to be able to engage and you're not just speaking to them, you got to make sure you have the right platform where they can talk back and forth.
Yeah.
But yes, I definitely think that there is a need if folks know it's available.
Are there other questions for Laura?
Ben, is there anything that you're thinking of that I didn't cover or that you think I should have mentioned or talked more about?
I think you did a good job.
Well, we're happy to stay on if anybody wants to talk any other questions, or even if you want to talk about your specific area, if we can give you ideas, we're happy to do that. If everybody wants to jump off and has the rest of their afternoon, that's good too. But we just wanted you to know we're here. My contact information is there, my email and phone number. Email is usually the best. Feel free to reach out if you have questions. Like I said, if I don't know the answer, I'll try to find someone that does or put you in touch with someone. But I just think that this is really important to continue to expand and think about and make sure it's on people's radar.
Laura, can you see the chat now?
Mhm.
Okay, so there was one more technical question that Diane asked earlier that I didn't feel that I didn't feel like I could figure that question out.
Yeah, I haven't, did you say, is that Diane? DL
Yeah.
is Diane? Okay. I'm not familiar. Is there a website, Diane, that you found that information? I haven't heard of that, but that doesn't mean anything. It could be just not familiar with it. And then are there other providers in other states such as Mayo that are also offering services? Would state lines make a difference? Yes, state lines definitely make a difference. You need to be licensed in Illinois to provide services in Illinois. Some states I think have some reciprocity. I don't think that's the right word, but something with licensure that works. I don't believe that we have that here. So both the provider and the patient, I think, both are supposed to be located in Illinois for the time of the visit, and the provider needs to be licensed in Illinois. So if you had a provider at Mayo, for instance, they would need to be licensed in Illinois, I think, to provide services in Illinois, or for patients that were located in Illinois. And again, that's something that probably will be looked at a little bit closer as we move forward, and they might reconsider some of those licensure rules and maybe have more reciprocity or whatever the proper term is for licensure. But I definitely, that is something to keep in mind. Okay, Diane said that she just did a Google for Illinois telehealth and found that. So there might be some, if you do that, there might be some places where you can try to look up locations.
Well, Laura, I know that when you first took this position, one of the things that you saw as a challenge was ways to encourage people to explore the option of telehealth and, figure out if it was a better way to serve patients. And then I guess it was both a blessing and a curse that people were forced into that without much chance to prepare. But it did save you from having to convince people that these remote options would serve patients and providers really well.
Yes. Yeah, I'd say we still have some providers that prefer just to see patients in person, but I think we have a lot more providers that think that it makes sense for at least a portion of their patients, or depending on what their patients are being seen for some of them.
Yeah.
So I've been in the clinic when they've been seeing patients that I never would have thought it made sense for telehealth, and it worked really well. For instance, a postpartum patient that had just given birth and didn't want to get the baby out in the cold and COVID, and that makes a lot of sense, and it worked. Now, other patients in that situation might really need to be seen or examined or receive an exam, so that might not work. But I definitely think that it's kind of forced providers to take a look at their patients and diagnoses and see what makes sense.
Looks like we've exhausted all the questions in the chat space. So Laura, I just want to thank you for sharing with us this afternoon. It's been a hectic year, and I really appreciate this chance to kind of hear your report of how you responded and your reflection about how it worked and what you see as the potential for the future.
Yeah.
And so also thanks to Extension and Rural Partners for this collaboration that brings these issues to our webinar series. So thanks, Laura, for being our presenter today.
Yes, and thanks to Ben for jumping on with us. And I felt better knowing he was here to save me if there was a question, IT question I couldn't answer. And just appreciate this partnership. And again, check out Rural Partners and check out the Rural Affairs Conference, and keep in mind the next 2 telehealth presentations.
Thanks, Laura.
Thank you.